brief introduction on PPI by Dr. Gautam Ray, and then Professor Lahiri will be updating about its implication in nephrology practice. So, without wasting much time, I think we can start, Gautam.
Yes, good evening, everybody. And at the outset, I would like to thank Dr. Rajiv Sinha for inviting me. And I have known him for the last 12 years as a fabulous pediatric nephrologist. And it is he who basically, today I am in pediatric gastroenterology because of him. That's a long story. And it's my privilege to share the screen with, and the dais rather, with Madam Sushmita Madam, Arpita Madam, Dr. Pahadi, and everybody else. So it's a simple job for me. It's basically old wine in new bottle. So use of PPIs in pediatric practice. So we shall discuss basically the indications of PPIs in children, a little about gastroesophageal reflux and gastroesophageal reflux disease. Uh, what I would like to tell you is that my talk will be a little bent on the gastro part, so, and its relevance to PPI treatment. What is the evidence? What do international bodies have to say regarding the use of PPIs? We'll discuss some side effects of PPI use, chronic use of PPIs, and we'll summarize. So this is a very famous saying, all disease begins in the gut. May not be true absolutely, but definitely with the increasing importance of the gut microbiota and the role of PPI in chronic PPI therapy, or the role of chronic drug use and other factors which modify the gut microbiota, this definitely is an important aspect. So what are the indications of, well-known indications of PPIs? So gastroesophageal reflux disease, peptic ulcer disease, it is used in GI bleeding, and it is used when some drugs such as NSAIDs, high dose steroids, pancreatic enzyme replacement therapy, etc., are used on a long term basis. I have not mentioned the dose over here, but the doses are simple. Uh, Omeprazole, pantoprazole, lansoprazole, and esomeprazole are used. So most of those are 1 to 2 milligram. Omeprazole is 1 to 4 milligram per kg, given in a single dose per day. And esomeprazole is like less than 20 kgs children, we use 10 milligram. More than 20 kgs children, we give 20 milligram. And the best time to give it when PPIs are used is about 30 minutes before breakfast, because PPIs act best when the parietal cell is activated. So those were the indications where they should be used, where they have indications. But where is it being used in office practice? So in the community, it's like a child in a candy shop. Any pain abdomen often has a PPI on the prescription. Any child with anorexia often has a PPI on the prescription. We have seen PPIs being given for months together, along with the treatment of constipation for a typical constipation child. Any inpatient, when the child is admitted, has a PPI on the prescription. GOK, we had a fabulous medicine teacher, Dr. Amit Banerjee. Amit used to say GOK, God only knows. So often it is seen that when we don't understand and there is some discomfort in the abdomen, there is a PPI on the prescription. So I think it is time that we try to change our practice. So for that, let us go through the evidence where it may be used, and what are the legible indications. So a slide on gastroesophageal reflux and gastroesophageal reflux disease. We know that reflux is very common. Almost half of all infants regurgitate at least once a day. It peaks in about 4 months of time, by 4 months of age, and by 1 year of age, most of them, about 90%, subside. The reflux in 90% of infants subside, and PPI not to be used in this situation. Gastroesophageal reflux disease, which is the symptomatic or the complicated form of GER, this incidence, on the other hand, increases with age. And by adolescence, about 20% have it, which is almost akin to the adult incidence, adult prevalence. Yeah. So, empirical PPI therapy is justified in this subgroup, in this age group, those presenting with classic symptoms. But where there are warning features such as hematemesis or weight loss or maybe bilious vomiting, or children with extraesophageal manifestations such as asthma, where we may be considering an underlying presence of GERD, in such children, we need to investigate first, and an empirical trial of PPI therapy is not justified in such situations. The most definitive use of PPIs is in esophagitis. So, what are the clinical? Because an endoscopy is not readily available, may not be easily possible. So, what are the clinical features of esophagitis? In infancy, may present as irritability, may present as sleeping and feeding difficulties, may present as anemia. In children, the typical symptoms are retrosternal pain, epigastric burning. Like adults, there may be dysphagia or sour burps. So these may be symptoms related to esophagitis. Having said this, we remain, as clinicians, we often remain confused. What are the indications? Is it justified? Which product to use? What is the dose? For how long? Is cost is often a factor, and what would be the side effects? So then this is the time when we should fall back on evidence. So in pediatric gastroenterology, the body which the all over the world people follow is the North American Society of Pediatric Gastroenterology and the European Society of Pediatric Gastroenterology. Now, talking of recent evidence, there was this position paper which came out in 2018. It was basically on GERD, but uh, most of us write PPIs other than for drugs, what Dr. Rajiv Sinha mentioned in his introduction. We write it for the treatment of GERD or for the treatment or the diagnosis. So, what does Nesfagan have to say? Regarding the use of PPIs for diagnosis, the recommendation is that a trial of PPI should not be used as a diagnostic test for GERD in infants. As we discussed, a 4-week trial of PPIs for typical symptoms, heartburn, retrosternal pain, epigastric pain, in children as a diagnostic test for GERD is recommended by the working group. But all these are, mind you, weak recommendations because pediatric evidence is scant. And again, what we discussed just now, a trial of PPI should not be used as a diagnostic test for GERD in patients who present with extraesophageal symptoms such as maybe bronchial asthma or recurrent cough or recurrent pneumonia, whatever. Regarding the use of PPIs for treatment, I would just like to highlight two features. The first one is when we compare PPIs with placebo. Now, these are studies all done in infants. There were 6 studies, all on infants, which evaluated the efficacy of PPI in the treatment of crying or irritability. Mind you, these are situations where we commonly write or prescribe PPIs. None of these studies identified any significant differences in symptom improvement. I am unable to discuss the studies individually because of time constraint. And there were 4 studies of infants with gastroesophageal reflux disease, which were confirmed GERD, which used regurgitation as a primary outcome, and none showed any reduced frequency of overt regurgitation. Actually, in this age group, what PPI does is it decreases the acid output. But in this age group, regurgitation, the importance of acid in the pathophysiology of the reflux is minuscule, and thus acid suppression generally doesn't have an effect. And comparing PPIs and H2 receptor antagonists, the pediatric data shows that symptom control between H2RA and PPIs is comparable, but the evidence is scant. So if we talk of pediatric literature, then it is uncertain whether omeprazole is better than ranitidine in reducing symptoms of maybe esophagitis, whether omeprazole is better than ranitidine in improving histology or macroscopy on upper GI, whether omeprazole has more side effects. But since the evidence is low and evidence in adults is definitely, there is good quality evidence regarding erosive esophagitis that has shown that PPIs are superior to any other form of treatment for any other form of pharmacological therapy. So the recommendation, which is a strong recommendation, is that PPI should be used as first-line treatment of reflux-related erosive esophagitis in infants and children. And the other things we have already discussed: not to use acid suppression for treatment of crying distress, etc., in otherwise healthy infants, not to use acid suppression for visible regurgitation in otherwise healthy infants, and we have already spoken about the empirical trial and when to give it. So before I summarize, obviously, there are concerns about long-term therapy with PPI use in children. So a lot of evidence in adult literature, some evidence in pediatric literature. So I will mention only the evidence that we have in pediatric literature. So on the left, I'm sorry for this busy slide, I could not manage any animation. PPI causes hypochlorhydria, and this may compromise the acid-based defense mechanism of the stomach. What is the evidence? It has been shown that there is an increased risk of Clostridium difficile infection and other enteric infections. There has been shown to be an increased association with the risk of community-acquired pneumonia or respiratory tract infections. H2RAs or H2 receptor antagonists have shown to increase invasive infections in the NICU. Since PPIs have the same mechanism of action, PPIs may be having the same side effects with long-term use. Now, PPIs long-term use, it can cause hypergastrenemia. Hypergastrenemia has been shown to increase mucosal changes, both parietal cell hyperplasia, enterochromaffin-like cell hyperplasia, and the concern is that this may lead to increased risk of malignancies. But increased mucosal changes have been shown in some studies, but an increased risk of malignancy has not been proven. There is the concern that hypergastrenemia may lead to rebound acid hypersecretion when PPIs are stopped, but this is of uncertain clinical importance because tapering the medicine when we plan to stop the PPI often leads to annulment of this problem. Then hypochlorhydria may perturb electrolyte and nutrient absorption. Hypomagnesemia reported in adults, not in children, and vitamin B12 malabsorption reported in adults but not reported in children. Lot of studies, I'm sure Arpita ma'am will be talking about it, on bone, on calcium absorption, osteoclast function. Adult studies have both sets of evidence. They have shown increased risk of osteoporosis. Recent consensus possibly is that there is no increased risk of osteoporosis, but in children, the evidence, it has been shown that there is no increased fracture risk in children with PPI, long-term PPI use. Food allergy, the hypothesis or the potential mechanism is that since the food may not be fully digested, that may act as an allergen. In animal studies in mice, it has been shown that food specific IgE increases. It has been shown in adults, adults also, but there is lack of good pediatric evidence. Regarding drug interactions, lot of evidence in adults, but in children too, there is some evidence. In fact, it has been shown that in children, clopidogrel, use of long-term PPI with clopidogrel may attenuate the antiplatelet effect of PPIs. So as we realize, there is definitely a knowledge gap between the evidence in adults and the evidence in children. But just like in the movie Diwar, we never realized what Vijay would become when he became this thing as an adult. But the relevance is that adult studies cannot be extrapolated to children, and long-term studies in children are needed before we can make any definite conclusions. Even though there is not much evidence right now, it is best that we restrict PPI use only to clear indications and only for a duration and a dose which is just required. So summarizing, PPIs are often misused. Use should be restricted to established indications. Empirical PPI for 1 to 2 months is justified in older children with classical symptoms of reflux, GERD, but not in infants. And when indicated, actually, acid suppression therapy with PPI is safe and obviously very effective. And as we discussed, use should be restricted to the lowest effective dose and duration. Thank you very much.
Thank you, Gautam, for that nice summary. If you would you
Yeah.
just
Yeah.
yeah, and Arpita ji can share the her slides. So while Arpita is sharing, we will ask you one question. Uh, it has come up on the chat box. Like, given the choice, would you use a PPI or a H2 blocker as first choice?
For which indication?
So I will give you two indications. One is that where you are suspecting that the child is having maybe reflux or esophagitis, and second is that which comes to our clinic quite commonly, that pete means like pain abdomen, non-specific sort of symptoms. So what would you
Okay.
use?
So if it is a pain abdomen where I do not have a diagnosis, I may not use it.
Good.
And when I'm
So sorry, even if it is a epigastric pain, they are saying that epigastric pain and what sorry and what they always say that অম্বল হচ্ছে
yeah,
বাচ্চাদের অম্বল হচ্ছে.
yeah. So if it is an epigastric pain in an older child and I'm suspecting a reflux disease or an esophagitis, my first choice would be a PPI.
But you will use it for 4 to 8 weeks, not more than that.
Yeah,
Is
in
that the
fact,
message?
response comes in 2 to 4 weeks. But because if there is underlying esophagitis and we have not done or unable to do a endoscopy, and healing takes 4 to 8 weeks, that is why the duration is for 2 months.
And
One question to ask.
yeah,
Rajiv, can you hear me?
yeah.
Actually, we are prescribing low dose steroid when we are in tapering mode for SDNS, when we are using a steroid sparing therapy in childhood nephrotic syndrome. And along with that, people are in habit of writing regularly PPI and calcium. And how do you justify, Gautam, this use of long term PPI? Mostly people use lansoprazole along with this steroid.
Madam, we also use low dose steroids for autoimmune hepatitis and a host of conditions. We do not use PPIs. If
So,
there are
so
symptoms, then we will use.
So that's an important statement, and I'll come back to that at the end of this slide. One more thing, Gautam, do you have any preference over these various PPIs like esmoprazole, lansoprazole, and half of the name I can't even pronounce, and then there are granular forms. Any preference over one over other?
No, efficacy-wise, all are same on long-term use.
Okay.
Yes.
Okay, so we will have Orpita's talk, and then we will continue with the discussion.
Thank you, Rajiv, assembling us all on one platform and raising the question, which is very pertinent. If I want to start, I would start with about a statement of a wise patient who did ask me about 10 years back, Madam, I am taking pantoprazole for long time, more than 10 years. Is it safe to take? And as Gautam was telling about the GOK answer, almost like that, quite confused about this, because uh, I also didn't know this very clearly, that what is going to be the long term side effect of PPIs. I consoled the patient that probably not, but you know that using no drugs is almost always not having any side effect, so restrict the use only when you need. But I came back, and this wise patient made me read, and I did then find few case reports and case series published by that time. And I found that some studies are going on, but the conclusion was not yet in papers. So with that, I remember how patients make us read, and with that experience, we would deal with PPI and kidney. As Gautam was telling, that Orpitadi might be talking about the osteoporosis, I have restricted my talk to nephrology and PPI use. I haven't covered the other areas where PPI misuse or long term PPI use effect is also there. But now I feel that I should have taken it. Regarding osteoporosis, there is a consensus that PPIs do not cause osteoporosis, at least in adult population. Probably it is the most sold OTC drug. If you look at the company's uh, over the counter sales chart for heartburn medication, you will find that it has been sold, it has been a market share of more than 85% and an estimated cost of $2.6 billion. And it is proved by a survey that patients with CKD were prescribed more PPIs and for longer durations than patients without CKD. And as we know, that agotemic symptoms are at least partially taken care of by these PPIs. Patients eat food and appetite improves partially, and with that clinical feedback, we also go on using PPI. Probably we do not look at, but let's revise that what we do. We frequently overprescribe even when they do not need it. We rarely deprescribe. We can give it for acute symptoms, and when patients are comfortable, we should have withdrawn it. We do not stop, we continue on, because that gives us a feeling of comfort that the patient is not complaining. Often initiated inappropriately during hospitalization. During hospitalization, in various stress conditions, we start IV drugs, and when we discharge, we put them on oral version of that, and probably forget. পরে করুন, আমি ব্যস্ত আছি। Sorry. Often initiated inappropriately during hospitalization, and their use is continued for long term, even in absence of medical indication. Between 53% and 69% of PPI prescriptions are estimated to be for inappropriate indications. Excuse me for a second. Sorry.
সরি অর্পিতা দি, যদি সামনে থাকতে তাহলে জলটা দিয়ে দিতাম, আমার পাশে জলটা ছিল।
বাড়িতেও একাই আছি অলমোস্ট। PPI use is associated with what are the features that we have. Sorry. So what are the problems that we have? As Gautam was mentioning, hypomagnesemia and PPI, this is a concern. PPI use is associated with increased risk for hypomagnesemia, and the risk is amplified in patients who are concomitantly taking diuretics. The risk is increased with prolonged duration of PPI exposure. And it's even true for CKD and MHD as well. True for patients with CKD and MHD, because these patients are also on diuretics and it needs PPI withdrawal to rectify. Low magnesium corrected, it doesn't do. And surprisingly, the transplant patients study, there is one from transplant patients as well, that didn't show that much hypomagnesemia. So if we look at the adverse events with PPI use, we may find the non-kidney events like atrophic gastritis, B12 malabsorption, cardiovascular disease, difficile infection, increased community acquired pneumonia, dementia, gastric cancer, and osteoporotic fractures. When adverse kidney outcomes translate to be hypomagnesemia, acute kidney injury, acute interstitial nephritis, incident chronic kidney disease, and probable progression to renal failure. And this is also an important aspect, that it may increase all-cause mortality, death due to cardiovascular disease, chronic kidney disease, and upper GICA. We will come to that. And as we care about all these things, we are moving to next slides to look at the evidence and look at the features. The PPI-induced AIN is a difficult presentation, because unless you have a strong index of suspicion, probably you may miss it. Generally, well after months of initiation, leading to development of chronic interstitial nephritis. If you know that, if you consider the AIN in animal model, it takes only 7 days to progress to CIN. And in human beings also, the drug-induced acute interstitial nephritis, if it is not taken care in time, it is allowed to progress, not intervened by steroid therapy, it will progress to CIN very fast, probably be over 28 days or a month. So such fast progression of AIN to CIN often complicates the incomplete recovery of these patients and progression to CKD. Clinical features are subtle and diagnostic tests are few. Only biopsy is required for definitive diagnosis, which is not always a very easy option for different subsets of patients whom we initiate on PPI. PPI-induced AIN is often subtle and without systemic allergic manifestation. We know many drug-induced AINs are like that. Less than half manifest fever, only 10% develop rash, about 1/3 has eosinophilia. So the typical triad is present only on 5 to 10%. About 1/4 of patients are suspected to have PPI-induced AIN before a kidney biopsy. Only when in kidney biopsy some AIN feature comes and we start taking out the drug, if we don't get any infection together, then we realize that PPI may be the causative agent. So somewhat atypical presentation in PPI-induced AIN. Allergic manifestations are not there. A bland urine and a rise of creatinine may force us to look at the prescription whether they have in their prescription this PPI as well. PPIs were first recognized as a cause of AIN in 1992. Lots of case reports were there. Then case series started coming. An initial signal of PPI complicating PPI-induced AIN emerged when many of these patients did not return to their baseline kidney function after an AIN episode. So it may be now a AIN to CIN progression, AKI, AIN, partial recovery, progression to CKD. There was a beautiful study reported by Blank et al. I was quite surprised by the study design. Just read that it is a nested case control study. What was that? 2005 to 2009, any person who was initiated on new PPI use and did not have renal dysfunction or any event of AIN recorded before, they were compared, they were, if they developed rise of creatinine during the long-term PPI use, they were either biopsied or put on steroids, suspecting that, looking at the clinical profile and outcome. What they found, they took more than 5 lakh, close to 6 lakh patients without a history of interstitial nephritis or other renal diseases and new PPI use. The cases had first episode of AIN after cohort entry. 46 of them have histology proved AIN, and rest discharge or death record proved 26. So altogether 72 patients, and age and sex matched, and with propensity based score, what we tell, that controls were taken, that is 720 patients. And they found that recent users have a hazard ratio of 5.16. The elderly patients had much higher the risk than younger, and the crude incidence rate and confidence intervals per 100,000 patients years were 11.98 and 1.68 for current and past use. So current use of a proton pump inhibitor was definitely associated with significant increased risk of AIN relative to past use, and that is more in older individuals rather than the younger ones. So a CKD association from incomplete recovery of AKI AIN, inflammatory tubulointerstitial process, to progress over time to chronic interstitial fibrosis. From ERIC database by Lazarus et al., the findings that have come out, that was the self-reported PPI use at baseline, no CKD at baseline, but CKD at last visit. This was the population taken out from the ERIC database. We know that the ERIC database stands for the atherosclerosis risk in community. That database was used for exploring this PPI and CKD association. PPI users were found to have a higher rate of CKD compared to the non-users, and highest risk has been diagnosed CKD on the basis of validated hospitalization diagnosis with an adjusted hazard ratio of 1.5. So significant hazard ratio. About absolute increase for CKD in PPI users was 3 to 3.3%. Number needed to harm is 53. If you remember the huge population we prescribe PPI, 1 in 53 is also not a less number. CKD to AIN was that PPI use was associated with higher AKI risk as well. So the study also points out the 10-year absolute risk of CKD increase in PPI users 1.7%. Number needed to harm is 59. And higher risk was observed with twice daily PPI dosing. That also people do when our CKD patients complain of severe problem. H2 receptor antagonist use was rather not associated with this higher CKD risk compared to non-user in either cohort. This was another study which looked at the PPI use and CKD over 5 years following the VAD-T database. Here they looked at 73,000 people who were PPI users with 20-20-70 H2 receptor antagonist user. What they found on comparison, PPI users have higher risk. In incidence of CKD, in EGFR less than 60 ml per minute, that is again incident CKD, the risk is 1.22, and doubling of serum creatinine. These are all the renal outcomes we use in studies. So ESRD progression, doubling of serum creatinine, incident CKD, and total incidence of CKD. AKI risk was increased in PPI users. We can see the hazard ratio is 2.15. So risk for all renal outcomes that we use in our clinical practice increased significantly with longer duration of PPI use. So this is a study in which we are looking at the mortality association of PPI. This is a study of Z et al. Published in 2017 and again in 2019. So here they have looked at the PPI and mortality relation in both the studies, and the outcome I'm showing here. PPI and all-cause mortality, these are the causal inference studies. PPI use was associated with increased risk for death in general cohort as well as in patients on maintenance dialysis. Excess death due to CKD was attributable to PPI, was estimated at about 4.19 deaths per 1,000 PPI users. So 100 PPI, 1,000 PPI users, 4 death cause might have been attributed to excess death due to use of PPI. The excess burden of death was evident in patients without a documented indication for acid suppression drugs. So the side effects were more in which the drug was not indicated in the proper way. The findings are significant in that they provide evidence from causal inference studies linking PPI use to death due to CKD. So a reminder before we draw a conclusion that these are all observational studies. So whatever the statistics I have shown that show an extremely strong association of PPI use and CKD incidence, progression, AKI, AIN, but these observational data has to be looked at in an RCT, and people are doing that. The Z et al. Study that I have shown you for relation to excess mortality published in 2017 and 2019, actually that has been targeted, the statistics from that has been targeted to formulate a RCT. So people are on the way to have a real association of PPI and renal failure, particularly CKD and excess death risk. Till then, we should remember that we are looking at the observational studies which can prove association but not causation. PPI use in patients with CKD is quite fairly widespread because of non-renal clearance as well, and the ease of dosing, because we do not need to adjust the dose, and may also be associated with a rapid progression of the underlying CKD if a quiescent CIN is really happening. So remember that we should not be using it without indication. So what the message goes for us clinicians? PPI use should be discouraged when a clear-cut indication is missing, may use for short term when we really need them. We may practice some form of surveillance when we are using in early CKD or in normal population also, but of older age or just compromised GFR. We can look at the serum creatinine or the urine, which may reveal some sterile pyuria. GPs prescribing these drugs should be aware of both the short-term AIN and AKI so that they do not promote the long-term use of PPI without indication. Most of the patients from GPs regularly get PPI, and that is also not only GPs, that is also a practice from adult nephrologists as well. high index of suspicion when PPI-induced AIN should be considered in patients with unexplained serum creatinine rise or urinary abnormalities, urine analysis abnormalities, and we should be prescribing and encourage general population to do more and more routine urine examination, because routine urine allows me to look at the renal compartments very clearly, like a liquid biopsy. That we should remember. Prompting and finding these abnormalities, that should prompt a nephrology consultation and biopsy if required. And early intervention with steroid only can revert the situation. In a study, people have shown that AIN can be arrested from progression to CIN only if there is no delay in initiation of steroid. If the steroid initiation is delayed, AIN may progress to CIN. The planned and supervised process of stopping a medication is known as deprescriptions. We rarely practice this. Overuse of PPIs is not harmless, but PPIs are useful drugs. We know that its use has brought a real decrease in surgical intervention in gastric ulcer diseases, so peptic ulcer diseases. So overuse of PPIs is not harmless, likely driven by the misconceptions that this class of therapeutic is safe. Myself also had that before 2010, because only because of that patient that I came back home and I looked at that what is there on net, and I found the case reports and case series. The reality that clinicians often underestimate harms and overestimate benefits. Stopping the drug, switching to a H2 receptor antagonist for those who really require, because of their acid-related gastrointestinal disease, we should consider. And with steroids, considering steroids as a standard treatment of AIN, we may start when really we think of such situation. This is a deprescription protocol. No indication for PPI use, we should stop. Unknown indication, mild, moderate esophagitis or GERD for 4 to 8 weeks, we should lower the dose and stop and use on demand only. Peptic ulcer disease for NSAIDs, H. pylori treated for 2 to 12 weeks, upper GI symptoms, asymptomatic following treatment, or ICU stress ulcer prophylaxis, we should stop after certain period of time, and we should monitor for recurrence of symptoms and rebound hypersecretion. There was a case Viginet published in AJKD in which one person had developed AIN on PPI use, and after that with steroids it came down with a partial recovery, and on top of that, when again after 6 months he has been put on PPIs by some clinician, he again developed AIN and didn't come back to baseline creatinine anymore. So we should remember about that, and to do something and that despite our oath to do no harm, we fear missing a diagnosis more than the possibility of therapeutic misadventure. So we should be careful of, as we care, we should avoid therapeutic misadventure. And with that, I want to close my discussion. I would be happy to take questions.
Thank you very much, Arpita, for that excellent summary and giving us some guideline of when to start thinking of stopping the PPI. So we will now start taking questions. We have got a couple of questions on the chat box, so we'll take it first. One question is that Dr. Sakil has asked that, is it safe to give high dose steroid without PPI, for example, in nephrotic?
I think Gautam would be the best person to answer
Gautam,
that.
if you can unmute yourself. Gautam?
Yeah. 1 second. Yeah, Shakil, what was Shakil's question? Sorry.
High dose steroid.
Yeah.
Do you always need some either PPA or H2 blockers. So high dose steroids say 2 milligram per kg oral, or methylprednisolone when we are using say 30 milligram per kg.
Okay, so PPI should be given if there is a past history of peptic ulcer disease or if there is ongoing dyspepsia. But to prevent dyspepsia or to prevent peptic ulcer disease, we need not give PPIs as a routine.
So, Urpitati, what is your practice for 30 milligram? Like when we give a pulse
Yes,
methylpred,
we
do you
usually
routinely?
co-prescribe PPIs. We usually co-prescribe, particularly when it is in high dose.
But is there any evidence for it, or?
I think I didn't find any evidence. Gautam, is there any evidence for using
I looked into
PPI
pediatric
routinely?
Yeah.
evidence only. I'm sorry.
No,
Pediatric
no.
evidence is definitely not there.
Uh-huh.
Okay. No,
I also
we
couldn't
use in
find any.
pediatric age group quite frequently when we use 2 milligram per kg body weight steroid for nephrotic patients, and that becomes as high, very often becomes as high as 60 milligram because
Yeah, fine. But that would be short term. So short term we can use.
Yeah, but
I'm not talking about evidence, but short term we can use.
but like my question is that if I don't use it, then like now everything goes into the medical legal, uh, and we are afraid everything like you are in between you said rock and the hard rock, hard place. So if I use it, then and if the child develops say acute interstitial nephritis, then I am in trouble. If I don't use it, then also am I in trouble? Like if the child develops gastritis, medical legally,
Yeah,
any
if you
comment?
don't use it, then the child may develop a peptic ulcer. If you use it, it might develop kidney complications. So I think we should go clinically because you have evidence on both sides. So I don't know. I've never faced a judge. I don't know whether you have how tough it is. So
Gautam, what about using an antacid on complaint? If I write some antacid preparation, that the
yeah,
when the child complains, they do complain heartburn. They
yeah,
do complain. Not
yeah.
that they do not complain.
Yeah, I think symptomatic, that is the way to go. It should be symptomatic.
And if instead of PPI, if we use a simple like antacids, what's the problem
Yeah, in
then?
fact, in fact, PPIs take about 2 to 3 days to work. So whenever somebody has a heartburn, the practice is to take a PPI expecting a relief. So PPIs take about 2 to 3 days to work. So if you want something to work very early, we should take an antacid.
একটু পরে
If you
ফটো
want
মিটিং
an
আছে
acid suppression to start early, it should be a H2RA.
Okay. So we do prescribe famotidine for uh, children who are on yeah,
steroids.
steroids. We do
Since,
prescribe famotidine,
yeah.
but also I find that quite a lot of lansprozole prescription as well.
Yeah, but I would maintain my stand that we should not use a medicine to prevent dyspepsia or to prevent something. I mean, that is based on if there is a
So
past history
parents
of
should be
similar
taught that
disease
way.
or if there are other risk factors, then that may be justified. But routine use is not justified. At least there is no evidence for it.
Thank you.
And Urpitati, like in your experience or from your review, have you found any link like for how long you give PPI and then you start having complications including acute interstitial nephritis? Is there any link, or it can be
No,
from short use
didn't,
also?
they didn't mention any specific duration for which, but these long-term users are usually more than year. These long-term users that they have mentioned in their uh, mm, uh, cohort studies, they are usually more than 1 year, and definitely younger patients have less. So you might not be that scared to have AIN in a child who is given steroid as well as PPI. AIN may not be a threat that way because you are co-prescribing steroids as well, which will take care of that. And younger patients are relatively immune to it.
But like one of the message, is it right that we should not be prescribed like PPIs should not be prescribed on a on a drop of a hat.
Yeah.
And secondly, PPI should not be prescribed over a long term unless until you have evaluated it 2-3 times and be sure that you are prescribing it for the right reason. Am I right, Gautam?
Definitely, definitely.
So what, like, today only I saw maybe 2-3 cases. All these three were nephrotic on steroid. In fact, low dose steroid. One was on 5 milligram alternate day. The other one was on 2.5 milligram alternate day. And mother saying that or gas অম্বল হচ্ছে, and I hear this gas অম্বল almost, I'm sure Gautam must have gone mad with hearing gas অম্বল, but I hear this gas অম্বল also quite frequently.
I mean, I would rather ask you, have you heard this gas ombol when you were practicing in South India or abroad?
Yeah,
I mean,
among the Bengali patients which we used to see
yeah,
in.
so this is more of a cultural problem.
Now, is it cultural or is it genetic, or like, do we really have it or not?
No, there is nothing genetic in this.
So what to do in these cases? Because when you see the prescription, they are always on either, like most of them are on PPI or on H2 blockers.
Yeah, when you try to take them off, they'll have rebound hypersecretion and they will become symptomatic. So if there are no symptoms, you might as well taper them off in maybe 10 to 15 days, 20 days time, and tell
That
them
is
to
the
stop.
prescription.
Dietary modifications, lifestyle modifications. Most children are obese
So another
or
question
overweight.
which has come up is that concomitant use of PPI reduces the side effect of steroid, which you already said that it like preventive use doesn't like, there's no use, like no point in preventive use, right?
Side effect of steroids on the gastric mucosa.
Yeah.
Yeah, I mean, like may be there, but it is not to be used. I mean,
And the other question was that below 1 year, what will be your choice of PPI, Gautam?
if a PPI is indicated, the first thing what I would like to mention is that we need to first decide whether we want to do acid suppression or not. If acid suppression is indicated, then you may use any PPI which is available. If a PPI is not available, please use ranitidine.
And Arpita, your experience of using PPI on CAPDs, like, have you found high incidence of peritonitis, which is supposed to be there?
No. I did.
PPI in CAPD, you haven't found any high incidence of peritonitis in them?
Yeah, Rajiv, I should say that I have really we do not follow a huge cohort of CAPD, as I do follow a large cohort of
More.
diabetes patients. We have few CAPD patients in follow up, so they have GERD symptoms, but I didn't find any relation with peritonitis.
Susmita di, do you have any questions? Susmita di, Jayati di?
I just wanted to ask for patients who are on PPI for basically for no reason. I mean, have been started and by whoever, and has not without any specific reason, and you really want to stop. As Gautam just said that just stopping them would obviously increase the hypersecretion, and they will feel that they're getting the disease back, and they'll start PPI again on their own. So in these patients, is it prudent to replace the PPI with an H2 receptor blocker and rather than tapering? But is replacing a better idea of tapering? I mean to say.
I mean, if the patient is on long-term PPI, and I mean, you have a risk of tachyphylaxis with
Yeah, that's
H2RAs in 2
basically
to 3
wanted to ask
weeks.
about tachyphylaxis.
So rather, you may taper and use H2RA as a on an SOS basis.
Okay, so on an SOS basis, not as a routine
Yeah,
first.
if there is breakthrough acid secretion, if there is breakthrough dyspepsia,
Yeah.
then the patient may use H2RA on a symptom-based
Because the problem is most of these patients are they cannot come regularly, and they would obviously resort to phone calls, and it's extremely difficult to then actually understand what is going on. You don't even know whether there is an epigastric tenderness. You don't know what is happening. Just listening to the mother is sometimes very difficult. So in these situations, is it kind of prudent to prescribe for a short time, say for a week or say 10 days,
What is that? H2RA?
an H2RA, yeah,
Yeah, yeah,
and
definitely.
then then go on to SOS basis if they want.
Yeah, yeah. We are not stopping the PPI. We are making it like, if it is 40 milligram, we are making it 20 milligram. After that, we are making it 20 milligram alternate day.
Right.
If you want to give an H2RA for a month or so, I mean, absolutely justified. But then you are again you are using two drugs for acid suppression. Our
Exactly.
basic aim is to
Exactly.
decrease acid
Yeah,
suppression.
that is the problem. But most of the time, it's over the counter prescription. You don't need to prescribe, but they are just on it anyway.
Yeah, they may do whatever they want.
If any of the panelists have any more questions, they can put
Madam Dr. Banerjee.
on the chat box. And Susmita Di? Yeah.
My comment is that I think for all us pediatric nephrologists and for the adult nephrologists as well, the issue is, do we prescribe any, I'm not just sticking to PPIs, any antacid of any form, PPIs, H receptor blockers, or just plain antacids. Do we need to prescribe something when we are giving high dose steroids, as Raji has said? So are we saying after this, after everything we have heard from Gautam and Orpita, would we be willing to change our practice? I think most of us, when we use high dose steroids, we are still giving something that reduces or acid secretion or acts as an antacid. So are we in a place to stop that? Uh, um, as all of you have said, there is no real evidence either for or against these drugs. When you look at all our guidelines, none of the guidelines mentions using any of these drugs along with steroids either. So are we in a place to stop? And what I would like to compare this with is, I don't know if there are any of the rheumatologists out here. What happens when the rheumatologists are prescribing NSAIDs for a long duration? What do they do? Do they use these drugs for that duration of therapy, and that might be fairly long? So I think that is the comparator group. What are they doing, and what should be doing? What should we be doing from this point onwards? What do you think, Orpita and Gautam? And thank you for really good talks. Very interesting to listen to.
Madam.
I will take the question first. I think whatever rheumatology prescriptions from my institute people I have seen, they are regularly using H2 blockers either or PPIs along with NSAID prescription. And they continue NSAID for quite long time and they routinely write. And what I feel after treating the nephrotic syndrome pediatric age group patients, that many of the patients who were on steroids, they do not complain if I inadvertently forget to write the PPI or ranitidine, and they do not collect it from the hospital pharmacy, and they are not taking. When I was given this topic, I was just following in my GN clinic that how many patients I'm not using PPIs with steroids. And I found at least in 10 to 15 patients, when I specifically asked them that, are you taking this medicine? Even on 30 milligram steroid, they didn't complain of heartburn or acidity. And some patients did definitely complain that whenever they are on, even on PPI, when I usually ask them to take some mucane gel or some antacid, when they get the symptoms and to get immediate relief. As Gautam was telling, I do the same practice that I prescribe some antacid to get immediate relief. So with high dose steroid, not necessarily that they would require steroid, but for our safety purpose, we keep on writing.
So, we have Subhankar. Subhankar, in AIMS, do they prescribe? Subhankar, are you there? Subhankar?
Yeah, he's there. He just unmuted.
হ্যাঁ আনমিউট করেছে yeah in aims তোকে তো শোনা যাবে কিনা that is the biggest question but in aims did they use any H2 or PPI blocker because in PGI we were not using H2 or PPI blocker with steroid always শোনা যাচ্ছে না তুই মাথা নেড়ে এমনি এমনি কর ইউজ অর নো তো মাথাই নাড়া yes or no did they use or did no use no use okay শোনা যাচ্ছে না ঠিক আছে so we were not using in PGI I remember and they had a huge nephrotic syndrome clinic about 200 we used to have 200 cases between 2 to 6 শেষের দিকে মাথাও কাজ করতো না but they did not use the PPI or any H2 blockers for nephrotic so this is something that we can maybe start changing our practice we have one more question from Sumantra and as usual it is very complicated long-term PPI for gastrocystoplasty can be justified to manage hematuria dysuria syndrome so gastrocystoplasty means most probably means that like when you are augmenting your bladder with the help of gastric mucosa
এটা একদম bold. Over to Gautam.
Very sorry, I know.
so
maybe
so
maybe Rajiv the
no I don't know the answer but I'm giving you the concept like when you are augmenting the bladder you are using a patch of a gastric mucosa to augment the bladder and this and one of the problem that is thought is that this gastric mucosa bladder মধ্যে আছে and they are secreting acid and that can cause malignancy etc so in that condition where whether PPI long term use is justified
sorry
no
Sumantra. Thank you for your question. Food for thought.
Susmita di, Jayati di, do you have any answer to that? Or Subhankar, like any answer to, because I also don't have much experience with gastrocystoplasty. Whatever augmentation we have done is usually with the colonic
maybe you
and
need a urologist on board.
Yeah, colonic and all that. Okay. Sumanta said sorry to ask to the wrong panel. He didn't mention the wrong panel on it. Any other question? Subhankar to bolti parbe na. Sakil or Sunil? Sunil, any question? Sunil? So no question from there. So I think that's it then.
So I must thank Rajiv that you are really have done a good job that you have a practice changing session which should always be considered as a very good session that if it changes our practice of writing continuous steroid to nephrotic syndrome patients then it's really worth something.
Yeah, but it is something like হাতের মধ্যে এসে গেছে মানে we actually I want to
এটা করতে পারি we may write it to be used by patients if they need and to make the parents understand that
does that make sense Gautam like SOS
What is that?
SOS মানে পেটে ব্যথা হলে বা অম্বল হলে খেয়ে নেবেন does that make sense
H2RA.
I just read up something that says if there's a gastrocystoplasty done, then there's a very high chance of metabolic alkalosis, and because I mean like and
acid টা lose করছে তো কিডনিতে
so because of that but then ওখানে তো PPI তো কাজ করবে না in that situation will it not?
জানি না wrong panel
জয়তি মুখটা দেখাও না
I think if we stop writing PPIs and antacids and we have evidence that we can stop writing calcium, so that really simplifies the pill load for the patient.
but the problem is then then the patient thinks that ডাক্তারবাবু তো কিছুই দিলেন না, খালি স্টেরয়েডই দিচ্ছেন।
হ্যাঁ, আর অন্য কারোর কাছে গেলে 5টা ওষুধ দিত, অনেক বেটার।
থেরাপিউটিক মিস অ্যাডভেঞ্চার। আমার মনে হলো, আমার তো সত্যি সত্যি আমি এরকম হয় যে একটা পেশেন্টকে কিচ্ছু লিখতে পারছি না, কোনো মেডিসিন, পেশেন্টটা মাথা খেয়ে নিচ্ছি, কিচ্ছু বলছে না। আমি হয়তো বললাম, আচ্ছা আপনার পেটের অসুবিধার জন্য কদিন একটু র্যানিটিডিন খান, কিন্তু দেয়ার ইজ নো ইন্ডিকেশন অফ র্যানিটিডিন। কিন্তু হয়, খুব বিরক্ত করে যে পেশেন্ট, তাকে র্যানিটিডিন লিখে পাঠিয়ে দিলাম বা একটা ভিটামিন লিখে পাঠিয়ে দিলাম।
So for my practice, what I have done at the moment is, after much is that I've stopped writing PPIs for or even H2 blockers when they are on alternate day steroids. When they are on daily steroids, I'm still writing it. So hopefully we'll come to a where we can stop for the daily steroid, because I think it is not required, most probably.
Anyway, most of the time, patients who are on alternate day steroids, they would take steroids only on the days they are taking the medicine. They by default, they don't take it on the days when they are not taking steroids.
Rajiv, let's do a simple survey.
So it is not needed. I think let's end the session by saying that it is not needed. I mean, like, if we remain confused, then how can others follow the message? I think, I mean, like, it is not needed.
Yeah, I think so.
Yeah.
Maybe we can do a study also on this and prove our point. Subankar, তুই কিছু বলার জন্য?
Am I audible to you?
Yes, perfectly.
So actually the ISPN guideline that says that no need to use unless until there is a symptoms, as Dr. Gautam is already mentioned. So if required, we can treat appropriately, not like a prophylactic one. So even if it is a full dose steroid like 60 mg per meter square or 2 mg per kg per day, so some and most of the children doesn't require any acid suppression, but those who required, so we can prescribe as SOS, we can review their symptoms and we can treat accordingly. That's the ISPN guideline long back 2008. Dr. Bagga published in Indian Pediatrics actually. So that's practice is done in most of the institutions.
I think that is being continued. No, Susmita, I think that the guideline is almost the same in the updated one that we are trying to publish.
It's not going to have any priority at all. It's, it's
PPI H2 blocker will not be.
No.
So another question asked by Dr. Sumantra actually. So the problem is that the gastric mucosa, due to the gastric mucosa, that's the chances of hypochloridemia. So if the symptom is there, if we check that the chloride is losing, then you have to suppress the gastric mucosa in the bladder. Rather than, it's also not at the prophylactic one to use for long term. So not all mucosa, in the ectopic mucosa is going to lose chloride or sodium from their side actually. So that would be the answer. So my one question is here. So Madam is explained that very nicely. So the AIN pathology and everything actually. And she did mention that after 10 years, they have a good amount of statistically significant association. So any study that is using type of PPI, there's a lot of, generation of PPI is developed nowadays. Does all these PPI, unless the pantoprazole or other PPI, does cause this kind of CKD or not? Is there any difference between the generation of PPI and association of CKD? Is there any study?
I have not, at least the search I have made, I didn't find any. And most of the studies have mentioned PPI only as a class. They didn't mention any individual PPI.
Okay.
When they have selected patients, they have mentioned as a class.
Okay, ma'am. Okay.
Just one question for Gautam. Apart from the subjective symptoms of dyspepsia, is there any objective non-invasive method in which we can understand or test for esophagitis or gastric peptic ulcer disease in patients who are on steroids?
Okay, on steroids.
On long-term steroids. We are mainly dealing with patients who are on the.
So when we are talking of reflux in infants, there are some questionnaires. So, but those questionnaires also have a sensitivity of around 70%. And non-invasive method of assessment of gastroesophageal reflux disease in I'm not aware. So it's basically symptoms based. This is what is called the PPI test. If there are symptoms, you give a PPI. If there is a response,
কতদিনে রেসপন্ড হয়?
sorry, yeah, 2
Yes.
weeks.
2 weeks.
2
Within
weeks.
2 weeks, there should be a response.
So, Gautam, if we want to collect some evidence really that whether our patients on high dose steroid, they do have some symptoms on steroid, just একটা survey.
Can we just do a pH of the saliva or something? Can that help?
No, if we are suspecting esophagitis, we need to do an upper GI endoscopy
Yeah,
and
that
biopsy.
is becoming invasive. I'm just saying, I mean, something non-invasive. Is it but something which can be done, much easier? Say a saliva, a pH of the saliva or something.
I'm
Can
not
that
aware,
help?
madam. I'll look into the.
I mean, because that can, if we
Yeah.
know of something, we can do it as a pilot study, and find
Yeah,
out.
I'll try to find out, but whatever little evidence I went through, nothing has been mentioned.
Okay.
গৌতম, আমরা যদি এরকম কোনো সার্ভের মতন করতে চাই আমাদের ওখানেই, ধরো অনেক তো বাচ্চাদের আমরা স্টেরয়েড দিই, তো ধরো আমরা দিলাম, দিয়ে what are the questions that we would keep in our survey to look at that whether they are really having GI symptoms or not?
If you are doing a study, then you have to see for symptoms. You have to do an endoscopy, and you will need to do pH study, multi-channel intraluminal impedance.
ওইসব হবে না।
হবে। আপনার যারা করছে, যারা ডিএম করতে আসছে, দুজন পিডিয়াট্রিশিয়ান, একজনকে দিয়ে দিন থিসিস।
আচ্ছা আচ্ছা,
না, why not?
একটু বসি,
Yeah,
পিজিতে গিয়ে বসি একটু।
sure, ma'am.
Okay, then. So we have also sort of generated one study, hopefully. So thank you very much for joining, and Orpita Di, very, very thank you for this enlightening session, and Gautam also, very thank you. And
Thanks,
to
Rajiv.
all the attendees,
তোমাকে
thank you very
এরকম
much.
সম্মিলনে সভা করার জন্য ধন্যবাদ।
Thank you. Okay, then. Bye.
দেখা হলো এই করোনার বাজারে, হয়তো কিন্তু আমি কতদিন দেখিনি। সুস্মিতা দিকেও এখানেই দেখছি। টাটা।
Thank you very much.
Thank you so much.